because we're lazy. We're going to do a lot of that today here. When it shows up on the test, it will show up as 160. Carbon dioxide. Notice that carbon dioxide is like don't worry about this number here. Carbon dioxide is only 0.04% of the atmosphere. This is a greenhouse gas. It's triggering global warming. That shows how potent this effect is, a small amount of gas. All right. This should also give you tremendous respect for plants who have to undergo photosynthesis using carbon dioxide as a raw material. Y'all familiar with photosynthesis a little bit? How they convert carbon dioxide, right? And so a giant oak tree is built from how much carbon dioxide in the atmosphere? 0.04. That should give you some more respect for the plants out there, all right? Instead of just looking down your nose at asparagus or things like that. Oh, it's just how much they're doing here. Right? They don't run around a whole lot, do they? Plants do. But how much running around do you think you would be doing if the atmosphere were only 0.04% oxygen? Huh? Think you'd be running around a whole lot? Skipping down the block? I don't think so. Have some respect for the plants for that reason. But notice that the partial pressure of carbon dioxide is close enough to 0 to round it off to 0. I'm not even going to give you 0.3 millimeters of mercury. We're going to round that off to what? 0. Close enough to 0 for our purposes. So 160 and 0. Now before I go on, do you think these numbers are going to change when the air gets into your lungs?
Yes.
What's going to happen, do you think, to the levels of oxygen? They're going to go what direction? Down, correct? So you're expecting the partial pressures and the percentage of oxygen to be doing what? Going down. What do you think is going to happen to levels of carbon dioxide in the air in your lungs? It's going to be doing what? Going up. So you're going to expect the carbon dioxide levels to go up from 0 to something above 0, right? Let's see what those numbers are. In the alveoli, notice what's happened to oxygen. It's gone from 160 down to about what? 100. So in the alveoli, it's what? 100. What's happened to carbon dioxide? It's gone up to what? 40. Now, these are red numbers for important reasons. Because you will see shortly that when the blood passes through the lungs, through the pulmonary circuit, all right, returning back to the left heart, we will always fully exchange gas. To repeat, you will always what? Fully exchange gas. Unless you are sick, unless you have severe pulmonary disease, in which case you might not be able to fully exchange, you will always exchange fully. Which means that systemic arterial blood that ultimately came from the lungs will look exactly like this. To repeat, systemic arterial blood will look, for all intents and purposes, exactly like this. Because we fully exchange gas. So arterial gases, you'd expect the partial pressure of oxygen to be what?
The same.
100. Partial pressure of oxygen would be what in arteria? 100. The partial pressure of carbon dioxide would be what? 40. Would you expect those numbers to be the same in a vein? No. What's going to happen to levels of oxygen in a vein? Will it stay at 100 or will it be higher or lower? Lower. So you expect that venous blood will be lower. What about carbon dioxide? Higher. And let's find out if that's true. Oh, we have to go through it before well, let me just show you that real quickly here. Oh, I missed it here. Sorry, I missed what I wanted. Let me take this sequential. I'm just going to confuse people if I'm jumping here. So I have to do this Henry's Law here first. So, Henry's Law. Henry's Law deals with the quantity of a gas that gets dissolved. Henry's Law deals with the quantity of dissolved gases. Henry's Law deals with what? The quantity. And there are two things that are going to affect the quantity of gas. One factor is how soluble the gas is. And this is going to be primarily determined by whether it's polar or non-polar. Because water is very polar, things that are polar would dissolve in that. And also partial pressure. Now keep in mind here, carbon dioxide is far and away the most soluble of the gases. Carbon dioxide it's got polar regions to it, dissolves very well in water. It's 20 times, roughly, that's a good round number, roughly 20 times as soluble as oxygen. I'm going to use that approximation in a minute. 20 times as soluble as oxygen. So where did my one working? Let's say I have an enclosed container here. I've got air on the top here. Let's say that I'm going to just make up some numbers here. I'm a professor, I can do this. Let's say the partial pressure of CO2. And you'll see a P with the CO2, that's partial pressure, carbon dioxide. Let's say here it's 100. And let's say in here, partial pressure of carbon dioxide is also 100 because we've given it time to reach equilibrium. And let's say for this volume, we have, let's say we have 20 grams of CO2. For this given volume, we've dissolved 20 grams of carbon dioxide. So, what will happen to the amount of carbon dioxide if I double the partial pressure? If the PCO2 goes up to 200, now how much carbon dioxide will be dissolved? 40. How did you come up with 40? Because Henry's Law tells you that the amount that's dissolved is proportional to what? Solubility and partial pressure. If you double the partial pressure, you will double the content of the dissolved gases. So far, so good? Yeah. Same setup, same volumes, but now instead of carbon dioxide, let's say that we have oxygen. And the partial pressure of oxygen in the liquid phase, also 100. Question is, how much?
10.
Somebody gave me the correct answer. 1. Why so little? Because it's what? Less soluble. How did I come up with that number 1? Because carbon dioxide is 20 times as soluble for any given partial pressure. Same partial pressure, right? 100 here, 100 there, same partial pressure, 20 times as much carbon dioxide can be dissolved, 20 times the content as you would for oxygen. What if we were to increase the partial pressure of oxygen from 100 to 200? How much dissolved carbon dioxide, how much dissolved oxygen would you have then? If you doubled the partial pressure,
2.
you would double that up to 2. So these are the 2 factors which are going to influence content. The partial pressure and solubility. Keeping in mind that at room temperature, oxygen is virtually insoluble in water. You're not going to be able to get your oxygen needs just by dissolving it in the watery part of your body, in your plasma, because it's just insoluble. Are you going to have trouble dissolving carbon dioxide in your bodily fluids? Very soluble, easy to transport that. But since oxygen is almost insoluble, can you dissolve it just in your bodily fluids to transport it around?
No.
Do you have something special that's carrying that oxygen then? What would that be? I'm sorry. What was that? What's carrying that oxygen then? You can't just dissolve it in plasma, it's almost insoluble. Hemoglobin. That's why you have to have red blood cells full of what? Hemoglobin to carry what? Oxygen, because it's virtually insoluble in water. That whole partial pressure. Back to Henry's line. No. Remember a moment ago I said that the partial pressure of oxygen was around 100. We're rounding up. This is 104, but by the time it gets, it's 100. And notice that carbon dioxide was what we said? 40. Right? This will be true of virtually every artery. Virtually all your systemic arteries are going to have that because it's all coming from the heart, all mixing together, it's the same one. But do you imagine that every tissue is extracting the same amount of oxygen from the blood that's going through it? Is every tissue dropping the same amount of carbon dioxide into it? So individual veins are going to vary a little bit in how much, what their partial pressure of oxygen would be versus their partial pressure of carbon. Individual veins are going to have a lot of variation depending on how hard that tissue is working. But normally at rest, if you're not exercising heavily, then the venous blood, which would be in a pulmonary capillary, venous blood, systemic venous blood is going to have an average partial pressure of 40 mils of mercury. This 40 mils would be an average venous, systemic venous partial pressure. That's how much oxygen has been dropped off. And the average amount of carbon dioxide in an average vein has gone up from 40 to 45. So these numbers here that you would find, these are numbers that you would find in the vena cavas, for example. Superior, inferior vena cavas would be roughly 40 and 45. So by the time they got to the pulmonary capillaries, they are 40 and 45. They're reflecting what your systemic venous blood looks like. Now again, at the tissue level, notice what's happening at the tissues. The oxygen is being dropped off. So in systemic capillaries here, oxygen coming in at 100, but it's going to be leaving at 40. So that's what's coming back to the vena cava. And notice that carbon dioxide is going up from 40 to 45. Why does this not work better? So what factors are going to have an impact on this here? Well, on efficiency of gas exchange, one is surface area. Is that you need to have a large amount of surface area. I mentioned that if you were to unravel all the alveoli, that they'd have a surface area like 100 square meters, like a tennis court's worth of. That's a huge surface area here. If the surface area is decreased, then you can have hypoxemia, too little oxygen. Hypercapnia would refer to too much carbon dioxide. And this happens, for example, in, you ready? Ready? What's the most common COPD? Anybody know? Emphysema. Emphysema. Write this shit down, emphysema. Because that's a problem in emphysema. Emphysema breaks down the alveoli. Instead of having lots of tiny little air sacs, you got a couple of big blebs. If you see an actual lung that has it badly, it is disgusting looking. So when you break down when emphysema, you break down all the alveoli, what's happened to the surface area? Surface area goes way down, which means are they going to be able to probably fully exchange gas? That's why you end up with these issues here. The thickness of the respiratory membrane, because gases have to move by what process? Diffusion. And diffusion is only good for very small distances. Now when they talk about the thickness of the respiratory membrane, it's basically the thickness to get from the air sacs to the inside the capillaries. Now there are factors here, obviously the simple squamous endothelium here, but the big thing that can affect this membrane sort of thickness would be if there is fluid accumulation, if you start to develop pulmonary edema. So I would write in pulmonary edema. Pulmonary edema is characteristic of left heart failure. Pulmonary edema is an effect of left heart failure. Because if the left heart can't keep up with the right heart, well then the right heart is pumping all that blood where? To the lungs, right? Right heart's pumping into the lungs, but it can't get back to the left heart because the left heart just can't pump it all out. So as blood backs up in the lungs, the pressure inside the lungs is the blood pressure is going up. That's forcing extra fluid out. That's causing pulmonary edema. Is that going to make diffusion difficult?
Yes.
Is that person with pulmonary edema then in danger of not being able to exchange gases?
Mm-hmm.
Could they die at any minute?
Yeah.
Do you need to get fluid out of that patient rapidly?
Yes.
Yes. So if you've got a patient that's developing pulmonary edema, you need to act on that rapidly. You need to try to, if possible, strengthen the left heart if that's the issue. You want to get as much fluid out of them as you can, so you'll get them on a diuretic. Lasix drip, you just put them on Lasix drip, and they'll start peeing like a racehorse like within a few seconds here. That's how rapidly that works in a drip here. You get as much fluid out of that because some of that fluid is going to come out of the lungs. And then you try to strengthen their heart as best you can. Left heart failure, more common. a word about these terms, ventilation and perfusion. Ventilation, you already should know, sort of refers to air movement in and out, right? Perfusion refers to blood supply to that tissue. And normally those two are almost completely matched. It just happens to be that way. Which means that if your cardiac output is normally about 5 liters per minute, then your ventilation, your minute ventilation is also going to be roughly what? 5 liters of air per minute. If you're exercising and your cardiac output goes up to 10 liters per minute, well, then your ventilation is going to go up to 10 liters per minute. It's pretty much almost an even matching. And your lungs have an amazing mechanism to ensure that ventilation and perfusion are matched. And let me explain this because initially it looks weird, but hopefully it will make some sense in a minute. We had mentioned before that a normal capillaries that are feeding a muscle or something like this, all right? If oxygen levels are low, that's going to make those capillaries, the arterioles that lead to them do what? Dilate, correct? To give them more oxygen, all right? Pulmonary arteries and capillaries are just the opposite. In pulmonary arteries constrict when oxygen is low. Pulmonary arteries will dilate when oxygen levels are high. Just the opposite of systemic arteries. So here's my trachea. Here's my right primary bronchus. Here's my left one. Try to do at least a little bit so you can see the right is going to be a little bit more wider, a little more vertical. And here's the lung. And these are arteries going past. So these are the blood supply going past. I'll just try this for a second. So this is a normal, this is the way it will work here. So you're eating lunch here, you're busy, and let's say that you accidentally, aspirated cheese doodle. Don't you hate when that happens? And as I aspirate that cheese doodle, let's say it's going to get stuck in the right primary bronchus. Here's my, well, I should make it orange. And I don't have an orange. I'll make it green because it's like a little bit moldy maybe. That's really disgusting. So now, what's happening to ventilation in my right lung? It's basically stopped. It's being blocked because I've got an obstruction there. So how is the oxygen level going to compare on this side versus the left side here? So oxygen levels here are going to be what? O2 is low. And on this side where it's very well ventilated, oxygen would be what? If these arteries and capillaries were like systemic ones, where oxygen would be low, it would tend to cause them to do what? Dilate. And where oxygen was in overabundance, it would cause it to constrict. What effect would that have? Well, if that were to be true, that means you're going to be sending all your blood supply to the side of the lung that's worthless, to the side of the lung that's got no ventilation. And you bypass the lung that actually works, where there actually is ventilation going on. If these pulmonary arteries and arterioles behave like normal ones. But do they? No. They respond what? Just the opposite. So where oxygen is low, it's going to cause the pulmonary arterioles to do what? Constrict. And where oxygen is high, it's going to cause them to dilate. Big dilated vessel there. Big dilated. And so this mechanism ensures that the areas of your lungs that have the best ventilation also have the best perfusion. And those areas of the lungs that have the least amount of ventilation get the least amount of perfusion. So this is an automatic matching section so to ensure that your lungs are working the best they can. So this is sort of showing a low oxygen in the alveoli because of some kind of obstruction. Again, green, I don't know why green, another green cheese doodle. That would cause the pulmonary arterioles to do what? Constrict, so we're not wasting, all right? But if there's an alveoli that's got a lot of oxygen, well ventilated, it's going to cause the arterioles to do what? Dilate again, so we send all that blood to the areas that have the greatest. And carbon dioxide reflects the same thing, where carbon dioxide would be low, all right? Carbon dioxide would be low. It's going to cause the same kind of thing. Carbon dioxide, the same effect. Does that make sense to everybody? I'm hoping. Good. Efficacy of gas exchange. There's something I think I forgot to mention up here. This is a good number here. Typical transit time for red blood cell through a capillary is about 3/4 of a second. Let me explain that number to you a little bit. 3/4 of a second. Remember when we were talking about flow in the cardiovascular system, we had mentioned that because collectively capillaries have a tremendous cross-sectional area, that flow through capillaries was what? Extremely slow, correct? Remember that? To give us time for gas exchange, right? Mm-hmm. So the average time for a capillary they're sort of showing is what? That's 3/4 of a second. 3/4 of a second, that might not seem much to you, right? That's a long time, 3/4 of a second. But at that microscopic level, 3/4 of a second is a huge amount of time. Huge amount of time. And if you are healthy, you're not working too hard, most people are going to fully exchange before you're even 1/3 of the way across. So you have this huge reserve time. You're normally going to actually finish exchanging gas when you're about 1/4 of a second across. The rest of it is just a reserve time, and we'll see that in a minute here. But I wanted to sort of impress upon you that amount of time. 3/4 of a second doesn't seem like very long, but at that microscopic level, that's like an eternity. All right, now, gas transport. If you are normal, you're not anemic, all right, then every 100 mils of blood should contain roughly about 20 mils of dissolved oxygen. 20 mils of oxygen. How is that oxygen being carried? Is it dissolved in the plasma? No. What's it being carried by? What magic molecule is carrying that 20?
Hemoglobin.
Hemoglobin. So because of oxygen's poor solubility, less than 2% of your needs can be dissolved in plasma. Just a trace. We can just mark that out. That's an insignificant amount. The rest has to be carried by what?
Hemoglobin.
Hemoglobin. Diffusing red blood cells forming oxyhemoglobin. Now, each hemoglobin has how many subunits?
4.
4. So each hemoglobin can carry how much?
4.
4 molecules of oxygen. So the percent of the heme containing oxygen we refer to as saturation. If hemoglobin is fully saturated, it would have how many oxygens? 4. Could it be partially saturated with 3 or 2 or 1? Absolutely. And the ability of hemoglobin to load or unload depends, 1, on the partial pressure of oxygen. That makes sense. All right? But the other are factors that affect how strongly hemoglobin wants to hold it. All right? The affinity of hemoglobin for that. So let's take a look at those 2 things. Now this is a curve that you want to draw if you can, your drawing skills here. There's some important things to pull off of this graph here. Some really important things to pull off this graph. And when you're drawing this graph, there's a couple of things that you want to make sure that you get accurately. First of all, this scale at the bottom here, here's what you need to make sure. This is taking a look at partial pressure of oxygen. And at the end of the scale here, we have 100. And over here on the y-axis, we have got percentage of saturation of hemoglobin. So let's take a look at a couple of really critical spots. These 2 spots. Why are we looking at these 2 spots? Partial pressure of oxygen of 100. How saturated is the hemoglobin at that level? Close to 100%. It's not quite 100, it's probably closer to 98%, but for our purposes, we can round that off to close enough to 100, 98% or so, something in that ballpark. Can you get it to hold any more than that? No. That means if you are breathing normal atmospheric air that has a partial pressure of 160, right? Partial pressure 160, by the time it gets into your alveoli, it's down to what? 100, which means that at that level, your blood is fully saturated with oxygen. Can it hold any more? No. During football season, you will see the following. You'll see you'll see them, after a hard set of downs, all right? You'll see maybe offensive or defensive linemen coming off after they're working hard, run over the side, and you'll see them like sucking on a mask of oxygen. Have anybody observed this? While you're watching it, you see them on the sideline sucking on some oxygen, and that's when they're like, "Hi, Mom," right? Never "Hi, Dad." It's always "Hi, Mom." Poor dads. So they're saying, "Hi, Mom," right? While they're sucking on the oxygen, with the idea that they've just been working hard, right? Exhausting themselves. So if they breathe in pure oxygen, they should recover what? Faster, right?
Yeah.
Will breathing that in help them to hold more oxygen?
No.
Or are they already fully saturated? They're already fully saturated, right? So why do they do that? Well, could there be a placebo effect? Absolutely. If you think you're going to return, somebody tells, breathing oxygen will make you, yeah, okay, I'm feeling fine. First of all, let's talk about the athletic trainers that are feeding them this oxygen. Let's talk about the athletic trainers, all right? If you're an athletic trainer, if you're working for the NFL, I guarantee you at least have a master's. You'll at least have a master's. That's a guarantee, all right? And you're making some decent coin. You're probably making close to 6 figures if you're working at that high end for the NFL. You're making close to 6 figures. You're making some big bucks. Do they know this? Do the trainers know that? Do they know that they're getting little, if any, benefit from that? Of course they know that. They've had to pass this test. They all know that, right? But is even a $100,000 a year trainer going to tell a $6 million a year fullback or halfback, no, that's not going to help you a lot? Which of those two is going to win out? Let's think about that real hard. So that's why you see that in the sun. The trainers know that it has limited negligible effect. It could have a placebo effect, psychological effect, but in terms of actual improving training, no. Not unless that fullback who's on there has emphysema, in which case would they probably be part of the starting lineup? No. I don't think so. Right? If you have emphysema or not exchanging gas, are you going to be at 100? No. In that case, if you bump it up to 160 or 180, you're getting a couple of units of oxygen, then that can truly help you, all right, if you're not fully exchanging. But here's the other number to know here, all right? Notice that a PO2 of 40, go up here, you're roughly 75. That's close enough to 75. Now, why would these numbers be important? Where have we seen this number before? Well, this is systemic venous blood, right? Has a PO2 of roughly what? 40, which means that it still has how much of its oxygen? About 75%, which means when we talk about deoxygenated blood, is it really deoxygenated? Or is it just slightly less oxygenated? It's really just slightly less oxygenated. So systemic venous blood normally still has roughly 3/4 of its oxygen content. All right? So you're not using it all up. But when you do training, for example, or especially training for marathon athletic events, you get much better at extracting oxygen, which means that you're extracting oxygen, which means your partial pressures could go down to maybe 20 or so, which means that you're going to be dropping off what? Maybe 80% of the oxygen. When that blood that's got a PO2 of 20 gets back to the lungs, is it still going to get fully exchanged? It's still going to come out 100 by the time it exits the other end. You can't outcompete your lungs, right? Not going to limit your athletic performance here. So that venous blood normally still has 75%, a huge amount of reserve. So that's what we say. Note, venous blood possesses a large reserve of oxygen. Should human tissues increase? Now, this curve here, they call this oxyhemoglobin dissociation curve here. This curve can change. So, let me ask you these questions. See if we can come up with answers. Would you want hemoglobin to be able to release oxygen better, hold on to it less forcefully, be able to release it, decrease its affinity? Would you want that to occur in a muscle that was working hard? Would you want that muscle to have more oxygen? Yes. Would you want the hemoglobin to lessen its hold on oxygen then? Yes. What kind of conditions would you find in a hard-working muscle that would want more oxygen? Would it be a difference in temperature?
Yes.
What would the temperature be like? Higher or lower than normal?
Higher.
Higher temperature. What would carbon dioxide levels be like in that tissue?
Higher.
Carbon dioxide levels would be higher. All right. What would pH levels be?
Lower.
Because the more acidic, the lower the lower pH. Not only because of the carbonic acid that's being produced, but also because a hard-working tissue is going to be generating lactic acid. So all of those things that we've just talked about are going to decrease hemoglobin's hold, allow it to release more oxygen. And that's going to shift this curve in this direction. Let's see if we have that on the next slide. So this curve is showing normal body temperature, all right? But we're going to shift this curve over to the right here for factors that we would find in a hard-working tissue. High temperatures, high levels of CO2, lower pHs. Lower pHs are going to shift it, and that way we'll release more oxygen. At any given partial pressure, we will release more oxygen. So as it goes from the heart and it goes to the tissue, we're going to see it shift to the right. But at the lungs, we want it to load more easily, so the reverse conditions would make it easier to load instead of unload. So when we get to the lungs, we're going to shift the curve. Instead of the right, we're going to shift it to the left. So I don't want you to get an idea that this curve is a static curve, that your hemoglobin is always doing. It's constantly changing. When it gets to hard-working tissues, it shifts which way? To the right, so it can unload. By the time it gets to lungs, it's going to shift back to the left, so it can load more easily. So every time hemoglobin, or every time red blood cells make a circuit through your bloodstream, it's shifting to the right and then shifting to the left, back and forth all the time to make loading and unloading much more efficient. Now this last one here that's mentioned here about BPG. Here's clinically probably the most important thing about BPG. BPG is a byproduct of glycolysis, anaerobic glycolysis. And when tissues are working hard, even a red blood cell, when it's hot, will produce more of this. Now the key thing about BPG is that BPG will decrease it, allowing it to unload. BPG allows it to unload. And BPG is going to be found when tissues are working hard and they are warm. So the warmer the blood is, the harder it's working, the higher the levels of what? BPG. Now, clinically, this is where it comes into play. If you put blood into storage, if you take blood, you donate it to the Red Cross, you take a unit of blood, and you put that in the refrigerator, all right? What's happening to the amount of heat? Going down. What's going to happen to levels of BPG? It's going to go down. So, and if BPG levels drop too low, it's not going to be able to unload oxygen. BPG levels drop too low, it's going to grab onto oxygen and never let go. Is that going to be useful blood for a transfusion?
No.
To have blood that won't let go of its oxygen? So this is why BPG levels is one of the things that limits the shelf life of stored blood to normally about a month or so. Because after about a month or so being stored, BPG levels have dropped so much that the blood just won't release its oxygen. I will also mention this here is that fetal hemoglobin has a much higher affinity than adult hemoglobin because the fetus has to rip oxygen out of mom's body. It can only do that if its hemoglobin wants the oxygen more than mom wants it. So that's why it has to have a higher affinity so that darling, sweet little fetus inside of there that will be a thorn in your side for the next 18 years of your life. Bless it. Has to have a higher affinity hemoglobin. So it can rip that oxygen out of mom's body. It is a higher affinity. But of course, after the baby is born, that higher affinity means it won't let go of it. Which is why at birth, there's a massive turnover of red blood cells. Massive turnover from fetal to adult. Remember that we said that neonates, the newly born, are often subject to jaundice for that reason. Is this sounding familiar to anybody here? Mm-hmm. Because of this rapid turnover of blood cells when the baby is born, and that the liver that does that conjugation isn't quite fully baked yet, so that often you end up with this amount of all right, okay. Now we get into the worst thing you're going to have to deal with today, which is carbon dioxide transport. Carbon dioxide transport is complicated. Now, you would think it would be easier because carbon dioxide is so soluble. You don't need to have a mechanism for transporting it back. You can dissolve it in bodily fluids. But just because you can do it doesn't mean you actually do it. Now the truth is, the carbon dioxide that's released in your body's tissue, some of it does get actually carried back, maybe about 15% or so, just carried back dissolved, but that's a small percentage of it. Most of it gets carried back, about 7-10% gets dissolved in plasma. A little bit, about 20% actually gets carried by hemoglobin. Now, it gets carried on a different location. The hemoglobin has the iron in it where the oxygen is. It's the tail portion of it where we carry carbon dioxide. And we call it carbaminohemoglobin. Where's that term? Carbaminohemoglobin when it's loaded with oxygen. But by itself, just the carbaminohemoglobin and the dissolved, that only counts for 30%. What about the rest of it? That's 70% that we haven't accounted for. 70% of the carbon dioxide gets transported in the form of bicarbonate ion. 70% gets transported as what?
Bicarbonate.
Bicarbonate ion. Now, here's how this happens, and this might look just like a stupid thing, but you're going to see this repeatedly. Because this mechanism that you're going to find inside of red blood cells will be duplicated in the kidneys. We're going to see it duplicated in the stomach, because this is actually how you produce acid. What do I mean by that? Well, carbon dioxide will diffuse inside of red blood cells. And we have already said that carbon dioxide can chemically combine with water to form carbonic acid. Is that sounding familiar? Mm-hmm. By itself, that's an extremely slow process. Extremely slow for that to happen by itself. However, red blood cells contain an enzyme that speeds that process up by millions of folds. A critical enzyme that shows up on tests that's called carbonic anhydrase. Carbonic anhydrase. Carbonic anhydrase converts carbon dioxide and water into carbonic acid. But because these reactions are reversible, it can also convert carbon dioxide, it can also convert I can do this, I'm a professional. It can also convert carbonic acid back into carbon dioxide and water. So the enzyme can actually work in both directions. But at your tissues where carbon dioxide levels are high, it's pushing it in this direction. That's why we're talking about it now. Carbon dioxide converts it into bicarbonate, which breaks down into a hydrogen ion and a bicarbonate ion. Now, what is the fate of these two things? Well, the hydrogen ion tends to be buffered. It's an acid. We need a buffer. You got lots of buffer. And most of it gets buffered actually by the hemoglobin. Hemoglobin is also a buffer. It buffers most of the acid that gets formed during the transport of carbon dioxide. So hemoglobin is actually a triple threat, because not only can it carry oxygen and carbon dioxide, but it also acts as a buffer. Buffers the acid that's being produced. Now what about the rest of it, the bicarbonate? Well, as bicarbonate starts to build up inside of red blood cells, it's going to want to diffuse from areas of high concentration inside the red blood cells to low concentration on the outside. So we're going to tend to lose the bicarbonate, but the problem is that bicarbonate has what kind of charge? Negative. And if we lose negative particles, we're going to need to replace it with something else that's also negative. And that's where this mechanism comes in. That's called the chloride shift. where we allow bicarbonate to diffuse out in exchange for allowing chloride ions to do what? To diffuse in. We refer to that mechanism as what?
Chloride.
The chloride shift. So in the chloride shift, bicarbonate ions are exchanged for what? Chloride. The chloride shift, where we are exchanging chloride for what? Bicarbonate. Keep in mind that this chloride shift can work in both directions, because at the tissues where we are loading up all the carbon dioxide, bicarbonate is going out, chloride is going in, but when we get to the lungs, everything gets reversed. So at the lungs, you'll notice that instead of bicarbonate coming out and chloride coming in, that bicarbonate is going back in, so we can reconvert it back into carbon dioxide, where the chloride comes out. Always keep in mind that those are happening reverse in different conditions. Now, what do I mean by this is universal? So we don't have a lot of time. Let's say, just go. Just to show you this real quickly. This is the lumen of your stomach here, for example. We're creating hydrochloric acid, correct? Hydrochloric acid. So here's my H and here's my Cl. Between hydrogen and chloride, what do I have? Hydrochloric acid. How does your stomach make hydrochloric acid? Well, it starts by allowing carbon dioxide to fuse in. And the carbon dioxide will be converted by this enzyme Ca, that stands for carbonic anhydrase. Carbonic anhydrase into what? Bicarbonate and a hydrogen ion, correct? So what happens to the bicarbonate portion of it? It gets exchanged for what? Chloride. What do we call that process? The chloride shift. In this case, we're going to exchange it for chloride, but we're going to allow the chloride to go all the way through instead of stopping inside the cell. So now our stomach has chloride. You know, stop on the inside. What happens to the hydrogen portion of it? Well, the hydrogen portion we pump into the stomach in exchange, in this case, for potassium. Not that anybody cares about that. But notice we are basically using the same system, just in a different way to produce stomach acid. We're using the same enzyme, which was what? Carbonic anhydrase. We're using that to produce our acid, carbonic acid. And in this case here, what happens to the bicarbonate? It gets exchanged for chloride. Every place. We see this in the urine too, because we use the same system to acidify urine if you need to get rid of fixed acids, for example. So this same mechanism is used 3 places, at least that I know, probably other places that I don't know about, because there's a lot I don't know. But at least we know it's used inside of red blood cells. We know it's used inside of the stomach. We know it's used inside the kidney. All that same process. Okay. So that's that exchange. And how are we doing? Oh, crap, right out of time. Okay. We'll spend a little bit of time, you know, I can't do it in lab today. We'll do it in the lecture next time. I want to start on digestive next time, and I have to spend like first 10 minutes talking about control of respiration because I didn't finish that. So on Thursday, and of course we have lab coming up in 10 minutes, which you'll all be here for. We're doing some more dissection hopefully today here. When we come back on Thursday, please try to read ahead on digestion.